Imagine you're sitting in the reading room looking at an abdominal CT scan of a patient, and this patient has a known history of colon cancer.
Right, which already has you on high alert.
Exactly. So you scroll through the liver and your heart just sinks. The parenchyma is completely riddled with these tiny hypodense spots.
And your instinct, naturally, just screams metastatic cancer,
Oh,
right?
yeah. I mean, the clinical team is probably already thinking about aggressive chemo or, an exploratory surgical resection. But what if, and this is the crazy part, what if by simply altering the magnetic frequency on a follow-up scan, those deadly tumors just vanish?
Just completely disappeared and revealed themselves to be nothing more than completely harmless, benign cysts.
It's wild. But welcome to the abstract art of gastrointestinal radiology. Today's deep dive is, well, it's a highly specialized mission. We are custom tailoring this analysis specifically for you.
Yeah, the medical students, the radiology residents, and the young clinical professionals who are actively working to sharpen that diagnostic eye.
Spot on. We are unpacking the Mayo Clinic Gastrointestinal Imaging Review by C. Daniel Johnson and Grant D. Schmit. And our goal today is to comprehensively dissect the core radiologic findings, the actual mechanisms behind these really tricky differential diagnoses, and the practical applications for GI pathologies.
It really is a masterclass in visual translation. And actually, the authors provided this brilliant metaphor for the process during the book's creation. They helped design the cover utilizing the abstract art of Wassily Kandinsky.
I love that detail.
Right, because to the untrained eye, a fluoroscopic study or an MRI is precisely like a Kandinsky painting. It's just a chaotic mess of lines, shadows, and varying grayscale gradients.
Yeah, it's just shapes on a canvas until you learn the language. Those shadows, I mean, they only make sense once you integrate a deep understanding of cellular pathology with radiographic physics.
Exactly. And this atlas trains that exact decoding process. It relies heavily on large, high-quality images and standardized cases rather than, dense blocks of text.
So we are going to decode that abstract art today. We're translating these radiographic signs into concrete clinical mechanisms. So let's start at the gateway, right? The esophagus.
Yeah, let's do it. The esophagus presents a really unique diagnostic canvas because the imaging thresholds here are just incredibly fine.
Fine is almost an understatement.
Seriously, when we evaluate a patient for reflux esophagitis using a triphasic esophagram, we aren't looking for massive structural deformities. We're looking for microscopic inflammatory cascades.
Right. And the specific radiographic sign for mild esophagitis is fold thickening. But the text notes the clinical threshold here is fold thickening exceeding a mere 2 to 3 millimeters in diameter.
Which is tiny.
It's impossibly small. As a resident, interpreting a moving fluoroscopic scan and trying to confidently identify a 3 millimeter pathological fold versus, I don't know, normal mucosal relief or just peristaltic motion, that's daunting.
It is, and it requires really meticulous technique. During the mucosal relief phase of the triphasic study, you were specifically analyzing the distal esophagus for this thickened, slightly nodular appearance.
Okay.
And the reason those folds exceed that 2 to 3 millimeter threshold, it comes down to the underlying pathophysiology of acid exposure.
Right. It's a physical response.
Exactly. The thickness is a direct physical manifestation of the chronicity of the reflux, the acidity of the gastric contents, and crucially, the failure of esophageal peristalsis to clear that acid.
Which perfectly explains the clinical reality of seeing this in patients with scleroderma, right? Because in scleroderma, you have smooth muscle atrophy and fibrosis in the lower two-thirds of the esophagus.
Yeah, the motility is completely shot.
So the acid just sits there, it bathes the mucosa, driving the exact inflammatory thickening you're talking about. But it's also vital to distinguish these static inflammatory folds from esophageal varices.
Oh, absolutely. That's a huge distinction.
Because varices are dynamic. They'll change shape and caliber based on the patient's intrathoracic pressure. And they have that classic serpentine sort of snake-like configuration.
Right, you're distinguishing a localized inflammatory response from portal venous hypertension. Two totally different clinical pathways. Now, while esophagitis requires spotting that tiny 3 millimeter change, the esophagus can also harbor these massive macroscopic anomalies.
Oh man, the fibrovascular polyps.
Yes. The atlas really highlights these, and for a long time the nomenclature for them was chaotic. You'd hear them called pedunculated lipomas or fibroepithelial polyps.
Until the WHO finally standardized it based on their actual histologic composition.
Right, and the size of these polyps is just a stark reminder of how dynamic a supposedly static scan really is. They grow on a pedicle, usually arising from the cervical
And
esophagus.
they can easily exceed 20 centimeters in length. 20.
It's wild. And because of that pedicle and their sheer length, they have extreme mobility within the esophageal lumen,
Yeah, and that mobility completely dictates the clinical presentation. Like, a patient can literally regurgitate the polyp into their own pharynx.
which is terrifying.
It really is. It can completely obstruct the airway and lead to sudden asphyxiation. So it's this critical, life-threatening presentation. Even though the mass itself is completely benign, it has zero malignant potential.
And when you're looking at these on a CT scan prior to excision, the diagnostic key is measuring the Hounsfield units.
Ah, right, to check the density.
Exactly. Because they are fibrovascular, they often have a considerable lipomatous or fatty component. Recognizing that macroscopic fat density confirms the benign fibrovascular nature and directly guides the surgeon's approach.
Which actually brings us to a really critical theme in this review, which is the danger of benign mimics. Because, spotting a lesion is only half the battle.
Right. Knowing when a lesion is a harmless mimic is what prevents this whole cascade of unnecessary, highly invasive interventions.
Glycogen acanthosis is the perfect example here. It's usually just an incidental finding, mostly in older patients. And pathophysiologically, it's just an accumulation of cytoplasmic glycogen inside the squamous epithelial cells of the esophagus.
Yeah, just increased glycogen. But on a double contrast esophagram, that cellular accumulation presents as these tiny 1 to 15 millimeter nodular filling defects.
And to an inexperienced eye, seeing a scattered array of nodular defects instantly sets off alarm bells, right? You might think it's a severe candida infection, or worse, superficial spreading carcinoma.
But the mechanism provides the differentiator. Because glycogen acanthosis is an intracellular accumulation, rather than an invasive fungal plaque like candida, these nodules maintain a really characteristic pattern.
They don't merge together.
Exactly. They rarely coalesce into those larger, shaggy plaques that are the absolute hallmark of severe candidiasis.
So understanding that cellular mechanism allows you to recognize the expected variations of the canvas, so to speak. You hold off on unnecessary aggressive antifungal therapies.
Right. And this challenge of parsing out structural changes, it completely shifts when we move down and evaluate the intestines.
Oh yeah, the landscape changes entirely.
Here, we aren't just looking for isolated structures. We are mapping out complex, dynamic, regional inflammation. Crohn's disease, for example, provides one of the most challenging imaging landscapes in all of GI radiology.
Because, and the text points this out as a crucial clinical trap, the radiologic findings correlate very poorly with the patient's immediate clinical activity.
They really do. It's so unpredictable.
Right, like a patient might present with massive weight loss and severe abdominal pain, yet you look at their imaging and it shows relatively quiescent disease.
And conversely, you might find severe fistulizing disease on a scan in a patient who feels, honestly, relatively stable.
Yeah, the mucosal healing and the deeper transmural remodeling, they just simply do not track perfectly with symptom severity.
Which means, because of that disconnect, you have to rely strictly on the visual hallmarks of the pathophysiology.
Right.
The book notes, Crohn's disease involves the small bowel in at least 80% of patients, and it involves the terminal ileum in 95% of cases. The defining mechanism here is transmural inflammation.
Meaning the inflammatory cascade penetrates all the way through. It goes through the mucosa, the submucosa, the muscularis, right into the serosa.
Exactly.
I've always thought of Crohn's disease kind of like a wildfire.
That's a good analogy.
Right, because it sparks up, burns fiercely through all the layers of the bowel wall in one specific location, but then completely spares a patch of healthy tissue right next to it.
Creating that classic skip lesion.
Yes, exactly. And then it just sparks up again further down the tract. It's completely chaotic and asymmetrical, whereas ulcerative colitis acts more like a continuous, superficial burn starting predictably down at the rectum.
Yeah, and that transmural wildfire mechanism you mentioned, that is exactly why Crohn's leads to such severe extraliminal complications.
Because the fire breaches the wall.
Precisely. The inflammation breaches the bowel wall entirely. This leads to fibrotic strictures, the separation of bowel loops due to mesenteric fat proliferation, which we call creeping fat, and ultimately it leads to fistulas and abscesses.
And this is where your choice of imaging modality becomes a massive game changer. Let's say you're evaluating a patient with severe, non-specific colonic inflammation, and you're trying to differentiate acute UC from Crohn's.
It's a common dilemma.
Right. The atlas highlights that finding complications outside the lumen, like a perianal abscess or perianal fistulas, that is a definitive discriminator for Crohn's.
And for mapping those tracks, MRI is just vastly superior to CT.
Oh, completely. It all comes down to fluid signaling.
Yeah, on heavily T2-weighted, fat-suppressed MRI sequences, the fluid within an active fistula tract or an abscess cavity is going to exhibit hyperintense signaling. It essentially lights up bright white against the suppressed, dark background of the pelvic fat and muscle.
A CT scan simply cannot provide that level of soft tissue contrast.
It can't. MRI allows the surgeon to literally trace the exact anatomical path of the fistula right through the sphincter complex before they ever make an incision.
It's mapping the pathology with physics. It's
Wow.
incredible. Now, while inflammatory bowel disease is obviously a primary focus, the intestines also host pathologies that are a bit more, well, animate.
Oh, we're talking about the parasites.
Yes, we have to talk about Ascaris lumbricoides, the large roundworm. The text details its radiologic presentation, and it's the striking example of catching a systemic disease process right in the middle of its cycle.
It's fascinating. I mean, the systemic life cycle itself is clinically significant, right? A patient swallows infectious eggs. They hatch in the small bowel, penetrate the mucosa, travel via the portal system to the lungs, perforate the alveoli, get coughed up, and then swallowed again.
Just a horrific journey.
Truly. But the radiological challenge here lies in how these parasites interact with our contrast agents when they're back in the small bowel.
Right, because we aren't doing a biopsy, we're just watching a barium study.
Yeah.
So when you administer barium to a patient with a heavy Ascaris burden, the contrast coats the outside of the worm.
Which looks very distinct on fluoroscopy.
Exactly. It creates this classic tram track or inner tube sign. You see two parallel radiopic lines outlining the parasite's cuticle against the radiolucent lumen.
And if the worm actually happens to ingest the barium during the study, which does happen, you will see a thin, dense, thread-like line of contrast running right down the middle of the filling defect.
Wait, so you are literally visualizing the parasite's own tiny alimentary tract?
Yes, exactly. You're imaging the gut of the worm inside the gut of the patient. Furthermore, on a modern ultrasound, these worms present as echogenic tubular structures within the bowel.
Oh, right, a bullseye sign.
Yeah, if you scan in a transverse plane, you see that bullseye sign, the echogenic worm, sitting right inside the hypoechoic fluid of the bowel lumen.
It is incredible what we can visualize. But, you know, this raises an entirely different set of challenges when we move to the surrounding solid organs.
Yeah, the accessory organs.
Because the GI tract does not act alone. The liver, the pancreas, and the spleen, these are the absolute masters of diagnostic disguise in radiology.
They really are. They produce these static illusions where completely normal physiology mimics catastrophic disease. Let's look at the liver's illusions first.
Okay, hepatic steatosis.
Exactly, fatty infiltration of the liver. It's an incredibly common metabolic response. But the lipid accumulation is rarely perfectly uniform.
Right, it's patchy.
Yeah, you frequently see diffuse fatty infiltration that completely surrounds an isolated island of perfectly normal, spared liver tissue.
Which we call focal normal liver. And this is exactly where the physical properties of ultrasound become super tricky. Because the surrounding fatty liver is engorged with lipids, it is highly echogenic.
Right, it looks bright on the monitor due to the increased acoustic impedance.
Yes, but that patch of completely healthy, normal liver tissue has less acoustic impedance, so it appears relatively hypoechoic or dark by comparison.
What does a hypoechoic spot usually mean?
It looks exactly like a neoplastic mass hiding in the liver. It's terrifying for a second.
To differentiate this metabolic illusion from a true malignancy, you must analyze the spatial behavior of the tissue.
Mass effect.
Exactly. A true neoplasm grows expansively. It exhibits mass effect, meaning it compresses and displaces the surrounding hepatic architecture. Focal normal liver exhibits absolutely zero mass effect.
You can literally trace the normal portal and hepatic veins coursing right through the middle of this dark supposed mass, completely undisturbed.
Which proves it's benign. A tumor would either displace those vessels, encase them entirely, or show abnormal neoangiogenesis. By tracking the vascular flow, you prove it's just an island of healthy tissue.
But the illusions can work in reverse too, which actually brings us all the way back to the scenario we introduced at the very beginning of this deep dive.
Ah, right. The patient with colon cancer.
Right. You have a patient with colon cancer, and a CT scan reveals multiple tiny hypodense lesions scattered throughout the hepatic parenchyma. Every clinical alarm bell rings.
Because colorectal cancer loves to metastasize to the liver via the portal circulation.
Exactly. But as we hinted earlier, those lesions could very well be von Meyenberg complexes, otherwise known as biliary hamartomas.
Right. And as medical professionals, we know hamartomas are entirely benign developmental malformations. They're just small clusters of disorganized bile ducts embedded in a fibrous stroma.
They carry zero malignant potential.
Zero. Yet on a CT scan, they appear as nonspecific low attenuation spots. They deceive the X-ray beams perfectly.
So relying solely on CT here is a huge, dangerous trap. To unmask the hamartoma, you have to shift your imaging modality to exploit its precise physical composition.
And this is where MRI becomes the definitive tiebreaker. Because von Meyenberg complexes are essentially tiny cystic clusters of bile ducts. They contain a significant amount of fluid.
Right, they're fluid-filled.
So when you run a T2-weighted MRI sequence, which naturally highlights fluid, these complexes become markedly hyperintense. They just shine brightly.
And then you administer gadolinium contrast to evaluate the vascular kinetics. A metastatic tumor typically shows robust enhancement due to tumor angiogenesis.
Right. It drinks up the contrast.
But a biliary hamartoma, being predominantly fluid and dense fibrous stroma, shows no internal enhancement whatsoever. You might see a microscopic rim of enhancement, but that's just the compressed normal liver parenchyma reacting to the contrast.
Exactly. It's not a tumor capillary bed. The MRI physics confirm the benign pathology. And that level of diagnostic precision carries directly over to our evaluation of the pancreas, too.
Oh, absolutely. Especially when analyzing genetic syndromes like von Hippel-Lindau disease.
Right, VHL.
The atlas notes that the classic abdominal presentation of VHL is a pancreas almost completely replaced by innumerable tiny cysts. But we have to understand the mechanism behind that replacement to really interpret the scan correctly.
Yeah, von Hippel-Lindau is an autosomal dominant inherited disorder. It's caused by a mutation in the VHL tumor suppressor gene. When this gene is inactivated, the cells lose their ability to degrade hypoxia-inducible factor, or HIF.
Right. And when HIF accumulates, it basically tricks the body into thinking it's constantly in a state of hypoxia.
It panics.
It does. The cells respond by pumping out massive amounts of vascular endothelial growth factor, VEGF. This unregulated angiogenic drive is what causes the profound cystic and vascular manifestations. It isn't just that they passively get cysts.
Right. The pancreatic parenchyma is structurally replaced by these fluid-filled sacs, driven entirely by this genetic misfire.
Consequently, on imaging, you see profound multi-organ involvement because alongside the pancreatic cysts, the dysregulated angiogenesis leads to highly vascular solid tumors.
Yeah, things like renal cell carcinomas, cerebellar emmanueloblastomas, and pheochromocytomas. So recognizing the diffuse pancreatic cystic replacement on a CT or MRI, that should immediately prompt a comprehensive systemic screening for those dangerous neoplasms.
It's all connected. Speaking of exploiting imaging physics to reveal systemic disease, the text outlines this diagnostic mechanism in the spleen that is honestly nothing short of brilliant.
I know exactly what you're referring to, the Candida microabscesses.
Yes. Finding Candida microabscesses in deeply immunocompromised patients.
It's incredibly clever because Candida microabscesses are notoriously difficult to visualize. On a standard abdominal ultrasound or just a routine CT, these tiny fungal infections easily blend right into the background attenuation of the normal splenic tissue.
They simply lack the contrast gradient necessary to stand out.
Right. But let's look at the specific patient population at risk here. These are often patients with severe hematopoietic malignancies like leukemia.
And what do they need? Dozens of blood transfusions.
Exactly. Every single unit of blood brings a massive load of iron into the body.
Right.
And the body has no physiological mechanism to excrete excess iron.
None. So it gets sequestered in the reticuloendothelial system, heavily loading the spleen, which we call hemosiderosis.
Right. And this is where magnetic resonance physics yield an incredible diagnostic advantage. Iron is paramagnetic. So when iron accumulates in the splenic macrophages, it causes local magnetic field inhomogeneities. On specific MRI sequences, particularly gradient echo or heavily T2-weighted sequences, this iron causes a rapid loss of signal known as P2 star decay.
And the practical result of that is amazing. The iron literally drops the signal intensity of the entire spleen, rendering the background tissue artificially pitch black on the image.
But the Candida microabscesses do not contain iron.
No, they don't. They are purely inflammatory fluid and fungal elements. So because the background spleen is now pitch black, the fluid-filled microabscesses retain their signal and just pop out brilliantly.
It's beautiful. The patient's iron overload naturally generates the perfect, high-contrast environment. The underlying pathophysiology of their transfusion history interacts with the magnetic resonance sequence to reveal a fungal infection that would have otherwise remained completely invisible.
It really is the ultimate example of decoding Kandinsky's canvas, isn't it? We aren't just looking at random shadows anymore.
Now, we're applying anatomical mastery in radiographic physics.
Yeah. We've learned to measure the inflammatory thresholds of reflux esophagitis. We've mapped the transmural, chaotic wildfire of Crohn's disease using fluid-sensitive MRI. And we've exploited magnetic properties to unmask the static illusions hiding in the liver and the spleen.
Because knowledge fundamentally transforms the abstract into the actionable. And since our mission today is explicitly educational for clinicians in training, we must reinforce this material. It is time for a clinical review exercise to test your translation skills.
All right, listeners, this is for you. Step into the clinical scenario.
You are evaluating the imaging and chart of a patient with a known history of advanced cirrhosis. The abdominal ultrasound reveals complicated ascites. The fluid is not simple and anechoic. It contains prominent echogenic floating debris and dense septations.
Okay.
Clinically, the patient has presented with a sudden fever, abdominal tenderness, and an elevated white blood cell count. Based on our deep dive into peritoneal pathology, what deadly condition must you immediately suspect, and what is the specific biological mechanism that caused it?
I'll give you a second to lock in your clinical reasoning. Cirrhosis, echogenic debris in the ascites, sudden fever. What are you thinking?
The diagnosis you most rapidly suspect is spontaneous bacterial peritonitis, or SBP.
Right.
The echogenic debris and septations on the ultrasound point directly to an infected exudative fluid rather than a simple transudate. And the mechanism is entirely internal. It is caused by the pathological translocation of enteric organisms, most commonly gram-negative bacteria like E. coli.
So because of the portal hypertension and altered intestinal permeability, these bacteria basically migrate directly through the intact bowel wall.
Exactly. They enter the mesenteric lymph nodes and they seed that susceptible acidic fluid. It requires immediate, aggressive antibiotic therapy.
Recognizing that echogenic debris is the exact trigger that saves the patient's life. As we conclude this deep dive, I want to leave you with a broader thought to reflect on regarding your own clinical practice. Consider how the sheer precision of the physics we discussed today is fundamentally shifting the trajectory of patient care.
Oh, the technological leap is profound.
Yeah.
I mean, we are no longer guessing at the pathology.
Exactly. Think about that patient with the biliary hamartomas we talked about. Decades ago, those hypodense spots on a CT might have led directly to an exploratory laparotomy, a highly invasive liver biopsy, or just agonizing weeks of waiting for tumor markers.
And all of that based on a misinterpretation of tissue density.
Right. But today, by simply adjusting our MRI parameters to analyze the fluid kinetics and gadolinium enhancement, we can definitively diagnose a benign von Meyenberg complex without ever making an incision.
It's incredible.
We are shifting modern medicine away from reactive physical trauma and toward precise, non-invasive digital mapping. The abstract art of radiology isn't just a picture, it's the ultimate roadmap for preserving human life. Keep studying the canvas.